the World Massage Conference.
Hello and welcome to the World Massage Conference. I'm your host, Eric Brown, along with my co-host, Scott Dartnell, for this presentation with Whitney Lowe on evaluating and treating upper extremity overuse disorders. So we're in for a real treat tonight with one of my favorite presenters. But before we begin the show, I just need to thank our sponsors who make all this possible. I'd like to thank Massage Envy. Massage Envy is the leading employer of massage therapists in the United States. To discover the benefits of choosing Massage Envy as your career, visit their website at massageenvycareers.com. And thanks to our daily sponsors, Massage Today. Massage Today is the news source for the massage and spa therapy community. Subscribe to the Massage Today News Update free e-newsletter at massagetoday.com. Massage Warehouse. Massage Warehouse provides massage therapists and related industry professionals with the largest selection of quality products at a great value. Visit their website at massagewarehouse.com. And the Upledger Institute. The Upledger Institute, founded by John E. Upledger, leads the world in light touch therapy training programs, information, and products. You can visit them at upledger.com. Massage Magazine. Massage Magazine Insurance Plus. Please visit them online at massagemag.ins.com for the best value in massage liability insurance. And lastly, BioFreeze, pain relief that works. To learn more about BioFreeze, ProSage, and the TheraBand family of products, visit them at biofreeze.com and therabandacademy.com. So I'm very excited about our presentation tonight. We're featuring Whitney Lowe, who's going to be talking about evaluating and treating upper extremity overuse disorders. Upper extremity overuse disorders are seen in almost epidemic levels in our healthcare system. Massage therapists can play a key role in proper identification and treatment of these disorders. In this program, we'll explore biomechanical factors, assessment strategies, and treatment methods for numerous upper extremity overuse conditions. And I'd like to introduce our presenter, Whitney Lowe. Whitney is recognized as an author on pain and injury treatment with massage therapy. His contributions to the massage field are wide-ranging and include professional publications, teaching, clinical work, consulting, and participation in national boards and committees. He's the author of books, Orthopedic Assessment in Massage Therapy, and Orthopedic Massage Theory and Technique, which are used in training programs in schools nationally and internationally. He's also been a contributing author to several other books. In 1994, he founded the Orthopedic Massage Education and Research Institute, that's OMERI, to provide massage therapists the advanced education they would need for treating orthopedic soft tissue disorders. Whitney, welcome back to the World Massage Conference.
Eric, thanks very much. It's great to work with all of you all again, putting forth together this wonderful program that you do a couple times a year. It's great to be a part of it.
Yeah, so we had you in the spring program looking at orthopedic assessment. Fantastic presentation. Always love listening to your work. It's just so clear. You're the ultimate professional presenter. I think I would like to be just like you when I grow up.
Right. Okay. Well, we'll all grow up someday, perhaps. Yeah.
So I'm just going to pass the mic over to you.
I'd like to be as popular as you guys when I get to grow up.
I don't know what to say. I am just going to hand the mic over to you and let you tell our listeners about upper extremity overuse disorders.
All right. Thank you very much, Eric. So our topic this evening is, I know it's evening some places, and I imagine some places it's not evening, but evening here. And I'd like to welcome everybody. Our topic is going to be upper extremity overuse disorders. And as we mentioned in the brief introduction there, these types of conditions are certainly something that we can see at epidemic proportions in our healthcare system. It is billions, truly billions of dollars that are spent on addressing upper extremity overuse problems in the United States, and the similar amounts of money in other countries as well. And one of the things that I think is particularly interesting about this group of conditions is the nature of these problems are ones that respond exceptionally well to massage therapy approaches. So this is a place where massage therapists can make a huge impact on the healthcare system and address a problem that is of truly epidemic proportions for healthcare of the average person. So to do this evening, I want to go through a couple different things, look at some of the common factors that lead to these upper extremity disorders, and then some of the more important things that we want to be looking at with both assessment concepts and treatment concepts as well. So let's go to the next slide here. And the first thing that I want to address is how the upper extremity is actually being used. We think about moving through the world with locomotion by the lower extremity being the limb that sort of moves us along in the world. We refer here to the upper extremity as being our limb of engagement with the world in another frame of reference. What this means is essentially we've learned to use the upper extremity to manipulate objects, to hold things, to do all of the various activities that we do out in the world. And by being this limb of engagement, it becomes the way in which we interact with all kinds of things in our world. I was reading some interesting statistics on upper extremity overuse injuries the other day that was looking at a sort of a ramped scale of of the frequency of these type of problems just from the 1980s at the advent of the computer up until the current day. And it's absolutely remarkable the number of injuries that have increased as we've gotten to a much more automated society because of the repetition that's happening in so many occupational sectors. So again, this is a primary reason that we see these types of things becoming so prevalent in our current world and healthcare environment. I want to look at several particular groups of individuals that have upper extremity overuse disorders in very large proportions. And, of course, they can happen to anybody, but we see these particular sectors being affected a bit more than others. If we go to the next slide, we'll see here is a representation of a group that, of course, you would assume to see a number of upper extremity overuse problems, and that is, of course, in athletes. The physical demands of athletic activities are such that athletes are doing all kinds of activities that the body was not ideally designed to be doing. I mean, you look at this individual here in this picture performing the butterfly stroke in swimming. It's one thing to swim through the water. We as humans can certainly move ourselves through the water and use the limb, the upper body, the upper extremity as a limb of locomotion in the water. But we were not designed for the amount and intensity of training that is required of, for example, a competitive athlete doing this type of activity. They are putting in incredible amounts of mileage each day for training in these activities, and this, of course, is one of the things that leads to the sort of repetitive overuse injuries that we see occurring over and over again. It's that same thing of thinking, well, it's not just the one time that does it, it's the hundreds and hundreds or thousands and thousands of times that lead to it. So these are sort of some of the things that we see, of course, in athletes, the repetitive motion and high force loads on those motions, too. When you think about the pace that they're trying to bring themselves through the water, or a throwing athlete that's throwing baseball, for example, doing that repeated numbers of time with very high velocity, it's those cumulative forces that really lead to the primary problems that we're seeing. If we go to the next slide, we'll look at another group that has a primary problem with this, and this is, of course, where we see perhaps a greater impact of the whole epidemic proportion on our healthcare system, and this is with occupational disorders. We have so many occupations which put a heavy demand on our upper extremity, requiring various uninterrupted repetitions of an activity like in a factory assembly line, or unnatural or awkward positions like you see the dental hygienist in here. These positions that we have to put our bodies in and often stay for long periods, or have certain additional forces that we're overcoming. You look at the person working in the shop there with the electronic equipment. Power tools put a high demand on the upper extremity for resisting the forces of those tools, and you do that in conjunction with long periods of time where they're overexerting, potentially having muscular fatigue happening at the same time. These factors all add together to put incredible stress loads on the soft tissues that we're having to deal with. So we can see this as a place where massage therapists can make a tremendous intervention in working with these various different patient populations. And, unfortunately, what we're seeing so much of in the healthcare system is a lot of traditional medical approaches being used to address these problems, which are not having a particularly high success rate. So that is sort of a clarion call for us to get out there and do something with massage and addressing these particular types of disorders. One other group that I wanted to bring into the discussion here, too, if we go to the next slide, This is a more specialized population, of course, but one in which we're seeing a tremendous increase in the number of upper extremity repetitive motion disorders, and that is musicians. Many people, you hear about the incredible physical exertions and the physical accomplishments of athletes, but musicians do incredible athletic activity if you look at the muscular demands placed on them for doing various types of musical performance. Long hours of practice every day, thousands and thousands of movement repetitions, especially with the distal extremities. You take, for example, the picture of this violinist here, and the number of repetitions of motion of that left hand while holding the violin in a very awkward position puts incredible loads on the finger flexor tendons and the tendon sheaths that are in this area. And the right arm, which is bowing the violin, is also doing many, many repetitions during the course of a performance or practice with very specific positioning of that bow. So all of those things lead to incredible stress and trauma. Then on top of that, with the violinist, for example, look at the position of the head and the neck while this is going on. It's a very awkward and unusual position, which is frequently dictated by the musical instrument. It's not something that a person can necessarily change in their ergonomic factors. So when we approach this as a massage therapist, we often have to look at what can we do given the constraints of the particular environment or the setting that's being used with in this instance, a musician, with the instrument that they're playing or the type of performance that they're engaging in. So there are numerous factors like this that can lead to accumulation and aggravation of some of those various different soft tissue disorders. We go to the next slide. We'll look at another couple of factors that play a part. There's all kinds of things that may play a part in further aggravating these various soft tissue trauma. And the thermal environments are certainly one of those. There was a recent study in the Journal of Applied Physiology that found that the combination of cold and repetitive muscle work fatigued muscles much faster than work performed in a thermally neutral environment. And we've known this, for quite some time, obviously by just personal experience, that it's hard to do things when it's cold outside because your muscles slow down in their physical activity, but it actually does lead to greater degrees of muscle fatigue if those muscles are having to operate in a cold environment as opposed to a thermally neutral environment. And we can see the extremes of temperature and the extremes of other types of stress play out on muscle tissue and other types of tissue too, in leading to a greater incidence of the fatigue of those different structures. This is a place where the history comes into this very importantly to identify what are some of those factors that may have led to the development of an upper extremity repetitive motion disorder. Are there extremes of temperature or extremes of environment that the person is doing their various activities under? So these will things that we'll want to make sure we identify as much as possible in the assessment and evaluation process. Going to the next slide, we'll look at getting into some specifics now about what actually happens with the development of an upper extremity repetitive motion disorder, repetitive stress injury. We have, in any type of muscle activity, some degree of tissue breakdown that is occurring at any point. And we have this happening all day long, every day, just from the nature of these various activities. You add on top of that an increase in physical demand or physical activity level, and the rate of breakdown exceeds the rate of tissue repair. We of course, have a great deal of tissue repair that goes on during the night as we are sleeping, and we go into that deep state of REM sleep, and there's a greater degree of tissue rebuilding and repair occurring, or on the days off in between the physical demands of what we're doing. There's some time for the body to recuperate. But if you do not have adequate recuperation time, then you have the accumulation of a lot of these factors building up in the body and leading to the type of chronic breakdown that causes these upper extremity repetitive motion disorders to occur. So let's get a little bit more specific here for a few moments and drill down into some of the details of how we identify the types of disorders that come about and what are some of those factors that lead us to them. I want to first begin looking at a number of anatomical factors here. So we'll go to this next slide. and we'll begin to look at some of those, just as an example, structures in the shoulder region. And I'll use as an example here the glenoid fossa. This is a very good example of how the body is having to overcome design, I don't know if we should say design flaws, but certainly design limitations that cause us, have us doing things that our body isn't ideally designed to do. If you look at this image here and notice the glenoid fossa is a very shallow depression in the shoulder. We think of this as a ball and socket joint, but as you can see, there really isn't much socket to this. It's really sort of a ball and a shallow depression, essentially, without being a very deep cup. And the shoulder, because of this, has the greatest range of motion of any joint in the body, but it is the soft tissues that restrain that motion. And because of that, it is the soft tissues which are absorbing very high force loads from the various motions that we're doing in the shoulder, or putting that shoulder in a position making it particularly vulnerable. The soft tissues are a crucial part not only of the movement that happens in the shoulder, but maintaining and holding that stability. So those soft tissues are doing dual roles of creating the movement, creating the motions in this wide-ranging movement in the shoulder, but also they are the ones that are primarily responsible for holding and stabilizing it. So in a place like the glenohumeral joint, this is where we see overuse disorders frequently occurring from these tissues becoming fatigued and unable to withstand those very high force loads that are being expected of them. Let's go to the next slide for a second. Another factor here that's very well illustrated in the shoulder joint as well. This has to do with narrow spaces that anatomical structures course through. Here we're looking at the subacromial space in the shoulder, and you can see the way in which various overuse problems are likely to develop here. If we look at the location of the acromion process, the coracoacromial ligament, which that top arrow is pointing to, and then the coracoid process down below, this region forms an area referred to as the coracoacromial arch. And as you can see in this particular image, there's very little space between structures in that coracoacromial arch, such as the light blue bursa that you see, the glenohumeral joint capsule, or on the upper portion of the humeral head, the supraspinatus tendon, which is just underneath the acromion process. Now, I want to make just a brief comment here. These pictures that we're seeing all come from the anatomy software program called Primal Pictures. And one of the things that's unique and different about this particular software program compared to what you see in many anatomy texts is when you're looking at an anatomy book, you're often looking at an artist's rendition of what they see during dissection. But these images were actually created by taking MRI information from a living person and directly importing it into the computer graphics program to create the images. So what you're seeing is the exact size, shape, and relationship of these different tissues in a living person. As you can see here, there's very little space between that supraspinatus tendon and the underside of the acromion process. And this kind of narrow channel which soft tissues must move through is one of the things that leads to the likelihood of repetitive motion disorders occurring for the superior rotator cuff tissues. Now, keep in mind from an anatomical perspective here, too, it's not actually visible in this particular image, but we have a large bursa that is sitting over the top of the humeral head that's actually over the supraspinatus tendon and underneath the acromion process. Remember, there's one more tissue layer up above that supraspinatus tendon, and it's that presence of that bursa in there which makes that space even narrower and more susceptible to some types of compression or overuse trauma. So we have a number of things that could potentially be in this area causing chronic overuse disorders. Not only that, one of the other things that a lot of people don't think about, and it's kind of evident when you see an anatomical structure like this, is that if the humeral head has been exposed to excessive forces which make some of these soft tissues somewhat lax, you can develop a condition called shoulder instability, where that humeral head is not being held firmly in position. As a result of shoulder instability, the humerus may bounce around in that glenoid fossa a little bit more than it normally would and cause it to impact the underside of the acromion process. And by hitting that acromion process frequently, you are compressing the supraspinatus tendon, possibly fraying those muscle or tendon fibers there, but also causing an impact trauma on the underside of the acromion process, and this can be one of the things that leads to bone spurs developing in this region. So these are a number of factors that can lead to mechanical traumas occurring in these tissues because of this particular anatomical arrangement. Let's take a look at the next slide here. Some more interesting things here at the shoulder, and I'm using the shoulder as an example for a number of these different factors because it illustrates it very well. But keep in mind, this can happen in a number of different locations around the body where there may be some of these same anatomical arrangements occurring here. In certain regions, there's very high loads that many of the soft tissues must absorb. Here in this picture, we're seeing an image of the tendon from the long head of the biceps brachii coursing through the bicipital groove and then going around the top side of the humeral head and attaching at its attachment site at the supraglenoid tubercle. Now, we learn our muscle and tendon attachment sites when we study anatomy, but keep in mind these attachment sites are not always directly on a bone, and this is a very good example of it. Here we see the glenoid labrum labeled also in this picture, which is a cartilage, a rim of cartilage that surrounds the glenoid fossa, and its primary function is to help deepen that glenoid fossa. The biceps tendon comes across the top of the humeral head and attaches through the labral tissue before it actually reaches the bone of the supraglenoid tubercle. And if there are repetitive or very high force loads on that biceps tendon by doing, for example, a very vigorous elbow flexion activity or high repetitions of that, it may constantly pull on that labrum and cause that labrum to tear. So you may have a deep internal shoulder injury happening because of repetitive use trauma from a tendon such as the long head of the biceps. There's also some interesting anatomical features with this biceps tendon that make it also susceptible to further injury. You don't see many tendons in the body that are doing what this biceps tendon is doing right here, which is taking almost a right angle turn. As it goes across the top of the humeral head, you can see the biceps going from the front side of the humerus and then having a very sharp turn as it goes across the top of the humeral head. It plays a major role in stability of keeping the humerus in the glenoid fossa because of sort of bracing and holding it down. But that also makes it susceptible to high friction forces from the loads that may be placed on the tendon if you're doing a great number of activities. So this can lead to various types of tendon dysfunction or other shoulder injuries because of the repetitive use trauma. You also notice there, just on the front side of the humeral head, a ligament that is spanning across the bicipital groove and holding the tendon in place. And there is a sheath around this tendon which helps reduce friction between the tendon itself and this transverse humeral ligament. Sometimes repetitive motion disorders cause an inflammation or irritation between that tendon and its sheath, which we know is a condition called tenosynovitis. So this is another type of thing which can frequently occur in various tendons in different regions of the body, but especially in the distal upper extremities. This is one place where you see the tenosynovitis possible in the proximal upper extremity here near the biceps tendon, but most of the time we see tenosynovitis complaints down around the wrist and hand region because that's where the primary tendons are that have sheaths on them that are traveling through those small tunnels. Let's take a look at our next slide here and another anatomical factor that leads to upper extremity repetitive motion disorders. One of the types of disorders that occurs with very high frequency in the upper extremity is nerve compression injuries. And these occur mainly because, again, we're using that upper extremity as our limb of engagement and doing a lot of different activities with that upper extremity. Here, the structure that's somewhat highlighted in green is the bicipital aponeurosis. It's a slip of connective tissue that goes from the distal portion of the biceps brachii over to the forearm. And underneath the bicipital aponeurosis is the median nerve, and there is a very narrow channel that nerve goes through as it's coursing right underneath the bicipital aponeurosis. So once again, narrow channels that nerve structures must course through are frequently a cause of upper extremity nerve compression problems occurring. And there are numerous examples that we hear about very often, especially things such as carpal tunnel syndrome, where the median nerve is coursing through a very narrow channel in the wrist. But there are a number of other tunnel and compression locations in the upper extremity that many of the upper extremity nerves are susceptible to. For example, the median nerve right here, about where that arrow is pointing, is just about to course in between the two heads of the pronator teres muscle. And this muscle can compress the median nerve in this region and lead to many inaccurate diagnoses of carpal tunnel syndrome when, in fact, the compression is actually on the median nerve much farther up in the forearm. And this can be a potential problem because, especially in traditional medical treatment, the treatment approaches for addressing the carpal tunnel pathology will just focus on the wrist and hand region and not look at some other potential sites of entrapment of this nerve farther up along its path. There is a principle of nerve pathology referred to as the double crush or multiple crush phenomenon, which has to do with the concept that a nerve can be compressed in more than one location, and that can lead to an exaggeration of many of the neurological symptoms that the person is experiencing. You can address one of these sites of compression and still have neurological symptoms occurring because of the double crush phenomenon. And this is one of the things that a lot of people in traditional medical environments don't pay a great deal of attention to, is looking at the multiple potential sites of nerve entrapment. In the median nerve, we spoke about potential entrapment with the pronator teres muscle, also at the carpal tunnel, and then farther up, more proximately, we have many potential sites up around the thoracic outlet region. The ulnar nerve has a frequent site of compression near the elbow in a place called the cubital tunnel, C-U-B-I-T-A-L, the cubital tunnel. And it can also become compressed in another small tunnel down around the wrist called the tunnel of Guillain. So there are numerous small channels and tunnels that neurological structures have to travel through as a result of the anatomical structures, and this leaves them very vulnerable to upper extremity repetitive motion traumas. Let's take a look at the next slide here. Another anatomical factor having to do with the way muscles attach in certain regions. This is particularly a case here with what we're seeing with the attachment site of the common flexor or extensor tendons in the forearm. Many of you are familiar with a condition called lateral epicondylitis, which is sort of the technical term for tennis elbow. The lateral epicondylitis is a condition caused by cumulative trauma of the attachment site of the extensor tendons right here at the lateral epicondyle of the humerus. But notice, if you look at the anatomical structure in this image here, you see several of those extensor muscles converging onto a very small location, this one small pinpointed spot where all those tendons are pulling. And this is one of the things, an anatomical feature, that leads these tissues to be causing this type of problem in this particular area, is the concentrated forces directly on that one extensor tendon attachment here. So when we see these forces being concentrated in one area, it's the kind of thing that leads to the traumatic breakdown of the tendon collagen matrix, which we know as tendinosis. And this is part of what happens in many overuse tendon disorders throughout the body, but especially those that we're seeing in the upper extremity area. So these are a number of the anatomical factors that may lead to us identifying certain upper extremity disorders. And let's take a look now at a few other kinesiological or biomechanical factors that also play a role in that. If we go to the next slide, we're going to look at some of the effects of tension and compression forces on different tissues of the body. So we have examples of chronic tensile loading and compression loading. Most of the tissue damage that we see from soft tissue injury occurs from one of those two types of forces, either excessive tension or pulling or excessive compression. The picture on the left is indicating a lateral ankle sprain as an example for excessive tension or tensile forces where that ligament tissue was exposed to too much pulling force. When you have a tension injury like this, the ligament will gradually stretch and gradually elongate to a certain point in which it will then tear after a certain degree of stretch. And this is true of any soft tissue. It can go through those various different stages. And compression forces we see on the picture on the right side as an example here where the brachial plexus may be potentially compressed between the clavicle and the first rib. So these various different tension and compression forces are factors that we want to watch for all the time when we're doing our assessment of what might be the causative factors here. Let's go to the next slide. And I want to show you an interesting example, too, of looking at some neurological components that can lead to an upper extremity disorder. And one of the reasons why assessment is so crucially important in identifying the primary causes of what might be leading to this. What we're looking at here is the serratus anterior muscle on the right-hand image, and then the posterior shoulder on the left side. If you look at that left-hand picture for just a moment, you'll notice the yellow arrow indicating the way in which the scapula moves in upward rotation during abduction of the arm. So when you're moving your arm in abduction and bringing your arm fully out to the side, that lower portion, the vertebral or the inferior angle of the scapula, rotates in an upward direction, in the direction of that yellow arrow, to help encourage abduction of the shoulder. Well, one of the things that happens is in order to allow that upward movement, you've got to have some muscles that are pulling the shoulder in that upward rotation. And one of the primary muscles that does that is the serratus anterior muscle. If the serratus anterior muscle is weak, which it can frequently become weakened because of nerve compression, the nerve that innervates the serratus anterior muscle goes through the upper shoulder region, and in fact it actually pierces the scalene muscles as well. And you can have compression of the long thoracic nerve, which is the nerve innervating that serratus anterior, in between the scalene muscles, or also by heavy backpacks or shoulder straps or bra straps or anything heavy that you're wearing across the top of your shoulder. It may compress that long thoracic nerve and cause a weakness in the serratus anterior muscle. When the serratus anterior muscle cannot adequately aid in the upward rotation of the scapula doesn't move upward as far, and then the humeral head hits the underside of the acromion process and may cause a repetitive motion injury like a rotator cuff tear or shoulder impingement syndrome. But we'll notice that in that situation, the true culprit was actually a problem in the serratus anterior muscle that wasn't accurately identified in the way in which it had affected scapular and shoulder biomechanics. So this is a reason for us to constantly make sure we look at all of these different biomechanical factors that might be playing a part in that. Okay, we go to the next slide here, and I want to just briefly revisit this idea of chronic tensile loads on tendons, because this is certainly one of the things that leads to very common upper extremity overuse disorders, the chronic loading from tendon structures. When you put a load on a tendon like this, it is transmitting that load to the bone, but the tendon is not designed for this kind of heavy-duty loading over long periods. You see the tendon from the biceps brachii here, and you think of repeated actions that somebody is doing with that biceps brachii muscle. It puts a very heavy load on that tendon, and you may see chronic degeneration in the collagen matrix, leading eventually to tendinosis and other types of dysfunction in the tendon as well. So the chronic loading is a key biomechanical factor that we'll want to identify when we're looking at various factors with our clients. Going to the next slide, we see another thing that's a major factor with clients, and we don't think about this often as an upper extremity repetitive motion problem, but posture is a key player for many upper extremity complaints. Bad posture can be one of the things that leads to muscle fatigue, muscle overuse, and the chronic degeneration that happens in many of the other upper extremity disorders that we see. So we can see this occurring both from postural problems, from constant loads, from like sitting at a desk like this person is here for long periods, holding certain postures, or the various different positions that a person is in when they're doing some of the very different occupational things that we looked at earlier. Those various postural things play a key part in what's going on with many of our overuse problems. Now to look at some of the key factors in the assessment process when we're trying to identify these various different soft tissue problems. If we go to the next slide here, one of the things is at the root of our identification of soft tissue disorders in the upper extremity when we're dealing with overuse problems is history. You've got to take a detailed history to identify many of these factors that we've looked at earlier, the biomechanical factors, the anatomical factors. Taking a look at the detailed history is a crucial part of this. This is one thing that many massage therapists don't do in a great deal of detail. A lot of times it gets kind of glossed over and skipped over, but you can get a tremendous amount of information out of the history if you do a good job of asking questions and really sort of pursuing a line of inquiry very detailed with your clients. We go to the next slide here, and we'll look at another key assessment factor, which is biomechanical analysis. You need to have some understanding of both the anatomy and biomechanics of any region to understand how these different factors occur. So as much as many people aren't truly keen on studying their anatomy, it's just like, when you're having somebody try to understand how something works, you got to break it down into the component parts of what's being stressed in the position that a person is doing something. If they're sitting here playing a piano, for example, what are the different positions that their arm or hand is in that is leading to the potential for something being a problem there? So we'll go through that biomechanical analysis and think about how those stresses would affect various different tissues that might be involved. Looking at the next slide, we'll see another key factor in the assessment process, and that is patterns that emerge. The different patterns that we see in certain soft tissue injuries, like a chronic a shoulder problem or upper arm problem, we're going to see certain patterns occur when we do active motion, passive motion, and manual resistive tests. And that's what we're looking to identify. Do those patterns point to any one particular type of pathology? Are they pointing to a muscle pathology? Are they pointing to a ligament problem or a nerve problem? It is the emergence and recognition of those different patterns that help you best identify what's going on with a lot of different soft tissue problems that you might identify. The next slide here puts all that sort of in a different perspective of something that I strongly lean on as very important with people, and that is the process of differential evaluation. We have to be thinking about what are some of the various different possibilities that might be occurring when we start evaluating these upper extremity problems. If somebody has nerve pain in their hand, it's easy to jump to the assumption that this might be carpal tunnel syndrome, but you really have to think about the possibility, might this be a pronator teres involvement, or might it be something like diabetes or MS or a systemic neurological disorder? What might be causing those different problems? This is something called differential evaluation, and it requires a much greater degree of clinical reasoning and critical thinking to think about how those signs and symptoms are put together and what they might be doing to cause the particular problems that you're dealing with. When we get to the treatment process, let's look at the next slide here. There's a couple of key things that I want to hone your attention on that are very important for addressing these upper extremity disorders. The first is this concept of matching the physiology of the tissue injury with the physiological effects of the treatment. And that means you don't want to rely on any one particular treatment recipe or routine or protocol, but you want to identify what kind of injury has occurred and what's going to be best for it. Looking at these two pictures that we saw earlier, we've got a ligament sprain on the left and a nerve compression problem on the right. You're going to use different types of techniques to address those two different types of problems. The ligament sprain will really require deep friction massage and some mobility methods and a number of things that are going to help that ligament tissue heal. The nerve compression problem on the right is really going to require a number of massage treatment methods that are going to help decrease the compressive forces directly on the nerve, but you're not going to go in and use those same treatment methods with each of those different conditions. So it's key that we identify the nature of that pathology accurately through assessment and can determine the best way to go about it with treatment. In the next slide, we see something here called the rehabilitation protocol, and this is a key part of any attempt to address upper extremity overuse disorders, and something that causes a lot of problems in the traditional healthcare system. What this has to do with is the way in which the body normally heals and how other forms of treatment are being used to help encourage that process. Too often, for example, we see people being given rehabilitative exercises to address a soft tissue disorder when they haven't really addressed the primary tissue dysfunction, and then the person gets worse by doing the various exercises. So what this means is when you've got an upper extremity problem, you want to make sure you address where that client is in the treatment process and not go too far into one of those stages before the client's ready for it. If we go to the next slide here, we can see, too, that this requires a much different role of the practitioner, because we are not only the clinician who is administering treatment, but we are also the educator who is helping educate that client about the various factors that might be leading to their problem, what we can do for them, how we may be able to help them. So we play that key role as both the client educator and the clinician working with them. This, again, requires us to have a much better understanding of what may be happening in many of these various different treatment disorders. On the next slide here, the last thing, the key factor on some of these treatments is that I want to emphasize is when you look at upper extremity overuse problems and begin to look at treatment strategies for addressing them, and again, we certainly can't get into that in a great deal of detail in this period of time that we've got together this evening, but when the more you learn about these and begin to look at various different treatment strategies, I want to encourage you not to get attached to particular recipes or routines, saying just do these particular things for anybody who's got a rotator cuff problem or anybody who's got carpal tunnel syndrome, do this routine. Because no two clients are the same. Each client may manifest slightly different symptoms in the way that they'll do this. So it's going to be your role as the practitioner to determine how that treatment can best be done with each one of those different unique clients. And so just to wrap up here on our last slide, I just want to put a thought out that really the key to assessment and treatment lies in balance, of us putting together a balance of our knowledge, of our understanding of these various different pathologies, and looking at the best way to incorporate a comprehensive treatment approach that is based on a sound assessment of what's going on. And when we can do that, it makes us far more successful and far more capable of addressing these types of soft tissue disorders with our clientele. So I want to thank you all very much for your interest in hearing some more about those upper extremity overuse problems this evening, and I'm going to turn it over to Scott, I believe, maybe gathering a few questions here for us.
Actually, I have gathered. There's quite a few questions for you, Whitney. I wasn't sure if Eric was going to jump back in there, but I'm happy to jump in.
Okay.
As usual, Whitney, very thoughtful, well laid out presentation. I really like that you focused on on balance and on treating each client separately and their injury as something that's unique to them.
Yeah.
I certainly, one of the things I picked up from your presentation was don't be in a hurry, even specifically with an athlete, to jump into a stretching or strengthening program before you really assess the extent of their injury. That program may add to their injury or already has added to their injury. So
yes, and this is so difficult in many situations because oftentimes if you have like an athlete or somebody in an occupation, they can't really stop what they're doing, and you have to find ways to make your treatment work in conjunction with what they're doing because they can't simply just stop it for the sake of treatment.
The other point I want to bring up was certainly your slides and your images, Whitney, are so clear and concise. You just did a wonderful job on that, as per usual.
All right, thanks, Scott.
And I just had, actually, I've had more comments and questions just from people saying that they really enjoyed, of course, as we always say, that your way of presenting and how well you put everything together. Our first question comes from Jeff in Maui, and he says, Whitney, you are my hero. Your approach to rehab includes 4 stages, including soft tissue normalization, which we were kind of just talking about. Yet in most literature there is no mention. Is there a notable source that supports this important yet often overlooked stage?
Well, I'm not aware of something that really does that in this level of detail, and that's one of the reasons that I put those concepts together in this rehabilitation protocol, because it's something that I saw was tremendously missing in a lot of the orthopedic literature and a lot of the literature that was talking about addressing these complaints. This concept also, for me, it came out of working in physical therapy and orthopedic clinics for a number of years, and seeing this happen in practice was, that people were moved into these strengthening and conditioning programs way too soon, and the condition would actually get aggravated. And so I don't know of a real comprehensive resource that really emphasizes the importance of that. That's one of the reasons that I kind of put it together within this whole concept of system, because I think it's such a crucial piece of information that's left out of a lot of the common practices in treating these types of disorders.
I had another question along that line, or actually comment from Phyllis Baker in Michigan City, Indiana, and says, thanks for mentioning that an injury can be more than just one level. It helps make sense when the picture sometimes doesn't always come together with a client.
Yeah, that's another thing, is that we've got to remember that all of these things can be various gray areas. And one other thing I wanted to make a comment about related to that is that, especially in this era of the way our healthcare systems are set up, when they're set up to give clients or patients a particular diagnosis of a specific condition or pathology. And you see, descriptions of those written up in articles or journal publications or whatever. But a lot of times the pathology that a person has is something that's just a combination of various different factors of things that are not working right, but it doesn't fit into one of those neat little categories. And this is in particular, I find it so incredibly interesting. There are, at least with the American Medical Association CPT codes, dozens of codes for all these various different pathologies, but rarely do you see people having a diagnosis of biomechanical dysfunction. And, muscle tightness leading to inappropriate function of those soft tissues. And so frequently that's really the root of the problem, but it often doesn't fit into those neat little categories and boxes of the named conditions or pathologies that we frequently hear about. So that's something really to keep in mind as we're looking at, how best to identify and treat these various different problems.
Well, it's even just as an example, as we start to, even myself, working less as a therapist and more behind a computer, I was watching myself. I caught myself in the window of the car as I was throwing the football with my son, and realizing how forward my shoulder was before I even started the motion of bringing my arm back with the football.
That's right. Yeah.
And, about 5 minutes into it, wondering why my shoulder was sore.
Yeah, that's right. So. Yeah, we all do those kind of things, and as much as we know about them, we often don't see those things happening with ourselves as well.
I have a question from Maria. Actually, she's online with us from Prague in the Czech Republic. She said, "Hi, Whitney. Thank you for another amazing presentation. Do you have any tips on treating oneself's shoulder and work with ligaments in your own shoulder, or any resources that she could find that you provide?"
For working with ligament injuries in the shoulder?
Or working on yourself as a therapist. Actually, Maria's been online with us a few times. She's actually a massage therapist in the Czech Republic, and there's not a lot of other people doing therapy, so she's doing some of her own self-care. So if you had any recommendations.
Boy, that's a tough one because of the anatomical arrangement of the shoulder, being able to do that. But I have to tell you, I have become an adamant supporter of the Theracane, which is just one of the many self-massage tools that are out there. But I've really grown to have a tremendous fondness for that particular tool because it does such an exceptional job of accessing, posterior rotator cuff tissues and rhomboids and those things that are hard to get to. You can do a pretty fair amount of really good self-massage with anterior shoulder region, but it's a little bit more challenging to do that with some of the posterior shoulder structures. But that tool, or many of the number of the other self-massage tools that are out there, can be particularly helpful for doing this kind of thing to reduce the cumulative trauma of the work that we do on a regular basis, the chronic tension that develops, the myofascial trigger points that develop, all of those things that lead to the chronic overuse problems. A tool like that can be a lifesaver. Just a couple of quick minutes in between clients or something like that is a great way to reduce the cumulative trauma that builds up in there.
You know, excellent answer, Whitney. It's interesting sometimes when we think of any problem with the brachial plexus and we're having any referral in our arm or down into our hand, we instantaneously think scalenes. And I have a question from Deb in Sherwood Park, and she asks, can the brachial plexus be impinged if a client has fallen up the stairs and found themselves on their wrist? It's like a very kind of a casual fall to the wrist, but has now developed those types of symptoms.
This could happen on any number of ways in which a person might injure themselves, and what you really have to do is to kind of take the biomechanics of the injury and think about what happened there. But let me give you an example of using this example that you brought up here with this question. A person may have, in this instance, fallen up the stairs and hit their wrist, but remember, nerve structures we see most frequently, and we hear about them most frequently, being involved with compression trauma, with something putting either a sudden or repetitive long-term compression force on the nerve that impairs its function. But nerves can also be frequently injured by excessive tension forces, where a nerve is rapidly or forcibly overstretched past its length. If you were to fall on an outstretched hand with the wrist hyperextended, both the median and ulnar nerves are being stretched at that point across the wrist, and depending on the way that person fell up the stairs, it would not be unusual, for example, to think about trauma to the upper neurological structures, maybe in the brachial plexus, because of the way their head or neck either hit or the way in which they fell and impacted it. You might have even overstretched some of those structures as opposed to compressing them at the moment. So being able to break down and identify the biomechanics of the injury forces at the point of impact is really important. You think about something like whiplash and the resultant neurological injuries that happen from whiplash. Oftentimes the trauma, especially like in a lateral whiplash injury, is not because of nerve compression, it's because of nerve tension, because the rapid elongation or rapid stretching of those neurological structures led to the symptoms being present. And then, in a situation like that, you cannot go in and treat this with specific, compression forces anywhere near the nerve, because that does not do anything to benefit a nerve healing. You got to get the compressive forces or any of the excessive tensile loading. Just has to have time to heal. There's nothing that you can really do with massage that will, significantly speed that process up.
We had briefly mentioned, we were talking about athletes, and when athletes have injuries or overuse syndromes, and they're not going to stop for us just because we tell them that's the best thing for them. But when they endure these long periods of chronic loading, say Jeff from Maui said is working with people that are canoe paddlers over long distance events, and they're developing all these postural muscle fibers, the way they're toned for what they're doing. What do you do in that case with someone? We had briefly touched on this. That someone is not going to change what they're doing. They're doing the same activity all the time. What can we do as therapists to relieve that tension on those muscle fibers?
Well, there's a couple of things that we can do. From a strategy standpoint, a treatment strategy standpoint, we can use the best, most appropriate massage or soft tissue treatment methods that will help give those tissues the ideal opportunity to heal. So that's, again, back to the issue of identifying what the nature of that problem is and choosing the most appropriate treatment methods. But another part of this is back to the whole issue of, how do you get the person to stop when they can't? And one of the ways that I have addressed that frequently was to tell the client, okay, look, here is the ideal scenario. Let's say, you quit doing your activity or you quit your job for 3 weeks. You do yoga every day. You eat right. You do your de-stressing exercises. You do all of these things. This will be the absolute optimal treatment environment. Now, let's look at this list realistically and say, how much of this can you actually do? Can you quit your job for 3 weeks? No, that's not really feasible. But is it feasible you could do 4 or 5 of these other things? Well, that's possible. So let's try to use as many of these as we can and take the best advantage and work with what we can do at that point to see if we can get better as much as possible.
We're going to take our last question before I turn it back over to Eric from Kelly in Charlotte.
Yeah.
And she asks, you talked a lot about tension and compression. Can you please talk a little bit about inflammation?
Yeah, well, inflammation is going to be something that's going to result from some type of tissue irritation. Let's say, the talk about tension and compression are looking at the biomechanical factors that cause tissue injury. Inflammation is the physiological reaction to some type of forces that may be aggravating a particular tissue. But remember, inflammation could come from factors that are not necessarily biomechanical in nature. You may have a systemic metabolic disorder or some other thing that's causing tissue inflammation. So inflammation is the body's physiological response to dealing with certain of these types of tissue disorders. So we may or may not be able to do certain types of tissue interventions or soft tissue treatment interventions if inflammation is present from an acute injury, but oftentimes there may be some low-level chronic inflammatory activity going on that can still allow for a number of our other soft tissue approaches in there to work very effectively. So there's a wide group of things that can potentially be done depending on what the cause of that physiological inflammation is.
We're finished with the questions, but I just quickly want to say thank you again, Whitney, before I turn it back over to Eric. I always enjoy your presentations, and we have so many people ask me, we'd mentioned it earlier, how do they access all the resources that you offer professionally?
Yeah, I probably should have put that up on one of our slides. They can get additional information about all the stuff that we've got, resources and other things that are available at our company's website, which is omeri.com, and that is www.omeri.com, omeri.com.
Well, thank you again, Whitney, and I'm going to turn it over to our host now, Eric Brown. Eric?
All right. Thanks again, Scott.
Thank you, Whitney.
And I should mention to our listeners as well, to get directly to Whitney's website, you'll see a row of blue buttons at the bottom of the broadcast screen, and you'll see a button that says website. So you can click that button and go straight to the website and take a look at Whitney's resources. I'd also suggest for the listeners that they go to the replay room at some point in the near future. You have access to all these recordings until April 30th, 2011. Check out the spring conference recordings, and Whitney has another presentation there on assessment and doing a differential assessment. So certainly worth checking out. So thank you very much, Whitney.
Yes, thanks a bunch, Eric. It was a pleasure to work with you guys again, as always.
And again, I'll just reiterate Scott's remarks. Fantastic presentation. Always great information, and a pleasure having you here.
Good.
So,
thanks again, Eric.
So Whitney, I believe you're going to go into the chat room after this?
Yes, indeed.
And what we're going to do in a few moments is play a little bit of a video. Do you want to tell the listeners, the viewers, what they can expect on this video?
Absolutely. When our topic here was upper extremity overuse disorders, so what I did was extracted a few of the selected clips from this upper extremity DVD, which focuses on both assessment and treatment of a variety of upper extremity overuse problems. So it's going to incorporate some examples of special orthopedic tests that might be used to identify the various types of soft tissue disorders, as well as a number of treatment techniques that are pretty effective for dealing with a lot of these types of problems.
Okay, so we'll look forward to watching that. Before we get to the video, though, I need to thank our sponsors that make all of this possible and make it all accessible to us. First of all, I'd like to thank Massage Envy. Massage Envy offers steady client flow, competitive wages and benefits, full and part-time positions, and a respectful, positive working environment. To apply for a position near you in the United States, visit massageenvycareers.com. And I'd also like to thank our daily sponsors, Massage Today, Massage Warehouse, the Upledger Institute, Massage Magazine, and BioFreeze. Remember again that all presentations, the trade show, everything is available for you until April 30th, 2011. And want to invite you, of course, to take the quiz. You'll see the blue button on the page. Click that. Take the quiz for a certificate of completion for CE reporting. For those of you in the United States who require NCBTMB continuing education credits, just follow the links on the member area for instructions on how to get access to those. And on behalf of the Massage Conference partners, Scott Dartnell, Melanie Hayden, we'd like to thank all the participants and our presenter, Whitney Lowe. Now, stay on the line. It'll take maybe about a minute and a half for the video to switch over for most of you, so stay tuned and watch this fascinating video.
The upper extremity is used extensively in our activities of daily living, and there are numerous muscles and soft tissues that can be injured in this region. Muscles, such as the rotator cuff group, must withstand high force loads and repetitive motions. These mechanical burdens often lead to soft tissue injuries in the shoulder. The Apley scratch test is used to assess shoulder motion and is usually used to evaluate capsular and non-capsular tissues limiting motion in the glenohumeral joint. The shoulder has the greatest range of motion of any joint in the body. Its movement and stability are governed by numerous muscles. However, it is also one joint where motion can be mostly limited by the joint capsule. Motion restrictions that affect the joint capsule are evident in the joint's capsular pattern, which is evaluated in the Apley scratch test. Begin the procedure by having the client turn around so you can observe the position that their hands are in. One arm is brought into abduction and external rotation, the other into adduction and internal rotation. If you see a limitation in the sides, this may be indicative of a shoulder pathology. The best way to see that and evaluate is to compare the opposite side. Let's do that now, Bailey, switching arms. This time, this one will be brought into abduction and external rotation, the lower one into adduction and internal rotation. Hold that position for a moment. If there's problems getting this arm into the abduction and external rotation, this will be indicative of a problem oftentimes with the capsule or other tissues that are limiting the abduction and external rotation in the shoulder. If a person has a problem getting this arm back up behind their back, or you see a very significant difference between where their fingertips reach in the two tests, it may be a problem with the other or opposite muscle groups. For example, some of the muscles that would limit the ability to adduct or internally rotate the shoulder. So this can give you information about either one of these shoulders and some of the different tissues that might be restricting range of motion. The drop arm test investigates the presence of rotator cuff tears. This test is most accurate if a tear is moderate to severe, so keep in mind there could still be a rotator cuff tear present even if there isn't a positive result on this test. The supraspinatus is the most commonly torn of the rotator cuff muscles. The reason it is so commonly torn is that it gets compressed and frayed as it rubs against the underside of the acromion process. In this procedure, we're going to begin with our client's arm in abduction. And first, just look, Bailey, hold your arm right here in that position. I want to see if she can even hold in this position. If they're having trouble even holding in this position, that could be evidence of a significant rotator cuff tear. The next step, however, will be to tell the client to slowly lower her arm down. And as she slowly lowers it down, I'm going to give a little punch or push with my fingertips to push it down. Her natural tendency is going to be to push that arm back up because I instructed her to hold it there and slowly drop it down. But if there's a significant rotator cuff tear present, when I give that little push, her arm will often rapidly drop down to the side and she won't be able to hold that position. What's occurring here is a procedure or a principle called reflex muscular inhibition. With the rotator cuff tear, when I give that sudden load to it, the pain comes on very suddenly and it shuts off the neurological activity to the muscle, forcing the arm to drop down to the side. This will be indicative of a significant rotator cuff tear. The Hawkins-Kennedy test is commonly used to evaluate shoulder impingement in the subacromial region. Several structures could produce pain in this region, so it's important to use this test in conjunction with other evaluation procedures. In the shoulder, the coracoacromial arch is composed of the coracoid process, coracoacromial ligament, and the acromion process. Numerous soft tissues lie under this arch and are susceptible to compression. They include supraspinatus tendon, tendon from the long head of the biceps brachii, and the joint capsule of the glenohumeral joint. The subacromial bursa lies above the rotator cuff muscles, but under the acromion process of the scapula. When not inflamed, it is actually a very thin structure, and its primary function is to reduce friction of the supraspinatus against the acromion process. Begin by bringing the client's arm up into a full forward flexed position, and from that position simply internally rotate to the end of the range of motion. If this procedure reproduces pain in the subacromial region or the anterior shoulder, it could be indicative of subacromial impingement. Again, we bring the client's arm up into full forward flexion, it's straight in front of her, and then from that position into internal rotation. Note that some people will report some discomfort on the posterior shoulder, and that is not necessarily indicative of subacromial impingement. That's often stretching of the rotator cuff muscles on the posterior side. If there is impingement, the pain is likely to be in the subacromial region or around the front side of the shoulder. The Hawkins and Kennedy test, as we mentioned, should be used with other evaluation procedures to identify which of the tissues in the subacromial region is causing the discomfort. The empty can test is one of the most common procedures for evaluating subacromial compression. While the test evaluates several structures, there's a greater emphasis on assessing compression on the supraspinatus. Have the client bring both arms into a position of full abduction and then horizontal adduction about 30 degrees. From this position, I'll have her turn her hands or shoulders into internal rotation as if emptying a can, which is where the test gets its name. Then apply pressure straight down on the humerus above the elbow, and just Bailey, hold that position there, and I'm going to press down with a moderate degree of effort. Good. And I'll identify if there's any pain or discomfort felt in her shoulders with this procedure. Any pain or discomfort that's felt in that region could be indicative of shoulder impingement. Now, in this position, let's come back into the test position once again. She may feel pain at any point in there, but if she does not feel pain until the very last step, when I push down, that's when it's most indicative of supraspinatus involvement, because at this point, the supraspinatus is being recruited to resist the pressure that I'm placing down on her arm. So this could be indicative of subacromial impingement at any step along that test, but the very last step is the one that gives us the most information about the supraspinatus. The near impingement test also evaluates subacromial impingement. However, it puts more emphasis on structures that are likely to be impinged beneath the coracoacromial ligament, such as the tendon from the long head of the biceps brachii. In this test, I'm simply going to bring the client's arm into full forward flexion as far as possible, and to see if that reproduces pain. Bringing her arm up into that full forward flex position can pinch or compress those structures underneath the front side of the shoulder. It's usually the tendon from the biceps brachii long head that's affected here when it's impinged under the coracoacromial arch. Again, fully bringing that arm up into forward flexion as far as possible and seeing if that reproduces the client's pain or discomfort. Most indicative for compression on the anterior side of the coracoacromial arch. Speed's test is a valuable method for evaluating dysfunction of the tendon from the long head of the biceps brachii. It is used most often to address the possibility of bicipital tendinosis or bicipital tenosynovitis. The tendon from the long head of the biceps brachii courses through the narrow bicipital groove on the anterior aspect of the shoulder. Due to the amount of friction and high tensile loads placed on the tendon, it is susceptible to tendinosis. The upper portion of the tendon has a synovial sheath, which may also develop tenosynovitis, an irritation or adhesion between the tendon and its sheath. Begin with the client's arm in a fully flexed position. Remember, the tendon from the biceps brachii goes through the intertubercular groove or bicipital groove in this area here. I'm going to have her hold her arm in this position. Also keep in mind that the biceps brachii has three main actions: shoulder flexion, elbow flexion, and supination of the forearm. So we're going to resist all three actions simultaneously. Bailey, I want you just to hold your arm here and don't let me move it. By placing my hand here and pushing down on her distal arm, I'm having all those actions engaged simultaneously. And I'm going to find out if there's any pain reproduced in her anterior shoulder from this position, and then also tell her just to slowly let go of that, and I'm going to push down as we go down in this position. She's still engaged in some contraction as we begin to go down, but the fact that I'm pushing down against it and engaging the resistance simultaneously is sort of dragging that bicipital tendon through the groove with a bit more tension on it than normal, and will often reproduce pain if a person has bicipital tendinosis or tenosynovitis affecting that tendon. Active engagement broadening methods work well in the posterior rotator cuff to enhance pliability. The first broadening technique is going to happen during the shortening phase. So this is as the client's arm is coming up into lateral rotation. The elongation phase is medial rotation. So get the client to keep this motion going just like this. Bailey, if you will, keep this motion going just about that pace right there. And each time she comes up into a shortened position, which is the lateral rotation, then we'll perform a broadening technique on those infraspinatus and teres minor muscles. So we'll broaden and then pause. And then broaden and pause. Each time, just a short broadening technique you're applying directly on those infraspinatus fibers to help encourage fiber spreading during the concentric phase. And one more. Right there, good. So the broadening technique with the active engagement that the client is performing is a great way to enhance fiber spreading and broadening in these important posterior rotator cuff muscles. Because the subscapularis is difficult to access, this active engagement compression technique is highly effective for addressing muscular dysfunction. In this technique, we'll access the subscapularis in the same way we did in the previous one by bringing the client's arm up into abduction, then applying pressure down on the subscapularis. However, this time, the client's going to be actively moving in medial and lateral rotation. She'll keep her arm moving back and forth in this motion, which will shorten and lengthen the subscapularis, shorten and lengthen as we apply static compression to that. So again, I'll contact the subscapularis just as we did before, find the edge of the scapula, come over the top edge of the scapula directly onto that subscapularis, and I'll get my arm in a position so that I can stay out of the way of her movement as much as possible. And now, Bailey, just keep that motion going from all the way up here and down, and back up and down. The fact that she's actively moving her arm means the subscapularis is in active contraction during this process, giving greater effect to the pressure because that increases the tissue density as she's engaged in the contraction. Good. Now, if we want to go even further with that, instead of just applying compression during this active motion, we can do this against resistance, so there's a greater number of muscle fibers recruited. If I offer resistance here to her wrist, I say, Bailey, hold that there, and I want you to push your wrist into that same position that we were moving. Good, good, all the way down. She's pushing against my hand using that subscapularis. Let's come back again and do that one more time, and push from here all the way down. She's using a concentric contraction of that subscapularis, which recruits more fibers during the movement. Now we'll add the compression to that. In this position, I'll contact the subscapularis and now push against my hand as you did. Excellent. Keep that moving all the way down. Good. The compression is during the concentric shortening phase here. Again, push and come all the way down. Let's do one more time there. Really working those fibers with active contraction and compression on them simultaneously. Very nice. Good. By bringing that subscapularis into a position of active contraction while applying pressure on it is much more effective than just the static compression alone. Active engagement stripping techniques also work particularly well in the posterior rotator cuff muscles for reducing irritable trigger points and muscle tightness. As you did in the broadening technique, have the client engage a lengthening and shortening of that muscle group. So this time, the lengthening is medial rotation, shortening still lateral rotation. Bailey, just keep that motion going just like that, up and down. And we'll perform a short stripping technique each time she comes down into the medial rotation. A little bit slower there. Nice. Good. So pause during the shortening and strip during the lengthening. Keep that going through a good full range of motion. Nice. This can be done with one or both thumbs if you'd like. Working infraspinatus and teres minor during the lengthening phase. If you'd like to do another variation on this, this could also be done slightly differently. If you just have the client engage a contraction right there, so I say, Bailey, hold this here and don't let me move it. And now slowly let that go. As she slowly lets go, we've got an eccentric activity happening in those same muscles during the stripping technique. Let's do that one more time. Hold this here, and now slowly let that go. Eccentric activity happening in the posterior rotator cuff muscles while a stripping technique is being performed. Using this stripping with active engagement is very effective for many posterior rotator cuff disorders. Active engagement stripping techniques are even more helpful for encouraging tissue elasticity and reducing tightness in the large elbow flexor muscles. For the active engagement stripping technique, similar to the pin and stretch, we'll start with the client in a shortened position, and then she's going to keep her arm moving just about this pace here. So Bailey, just keep the arm going up and down just about that pace like that. And then apply a stripping technique during the elongation phase. So as the elbow is extending, we'll perform a short stripping technique on each one of the times that she's coming down. Keep that going. Good. And once again here and down. And let's go a little bit slower there, so we can perform a nice, good stripping technique on those elbow flexors. Nice. You can work the muscles on the inside of the arm here using the opposite hand. Just keep that going again. And up. And stripping during the elongation. For another layer of intensity here to engage even more muscle fibers, we can have the client engaging in an eccentric activity of that muscle. So Bailey, hold this here and don't let me move it. Now she's got the elbow flexors engaged, and we'll apply a slow stripping technique now. Just slowly let that go. She's still pulling up, but working eccentrically on those elbow flexors as we do the stripping technique. Again, hold there. And short stripping technique. One more time. Hold this position and slowly strip and elongate those elbow flexor tissues. Good. Only perform about 3 or 4 of those at one time so that it's not too intense for the client, but it's a very effective way to encourage elasticity and elongation in those elbow flexor muscles. The pronator teres is frequently involved in nerve compression conditions and should be addressed for these disorders. Pin and stretch techniques are an outstanding treatment method for these conditions. The pronator teres lies close to the common flexor tendon attachments. It's easy to palpate as it is just medial to the antecubital space on the anterior aspect of the elbow. The median nerve passes between the two heads of the pronator teres muscle. For the pronator teres muscle, first locate the attachment sites of the pronator teres in the middle of the muscle belly. It goes from here across to the forearm like this. There's a space just on the front side of the elbow, and if you push your thumb in this direction across here, the first muscle you hit is pronator teres. So we'll put the pin on the pronator teres with the wrist in a pronated position. That's the shortened position. We pin the muscle and then stretch and elongate by turning the wrist into supination. Again, fully pronated position, the muscle is in a shortened position, pin it with the thumb, and stretch and elongate. If this particular technique causes any aggravation of neurological symptoms, then move to a different location so that you're not pressing on the median nerve. That is a possibility. Once again, shortened position, pin the muscle, especially on areas of tightness or restriction, and then turn it into supination, stretch, and elongate. The Pronator teres is frequently involved in many of our nerve compression disorders, and this is a highly effective way to help encourage tissue elongation in that muscle. The position used in the upper limb neurodynamic test number 1 is also used for median nerve mobilization. Similar to the ulnar nerve mobilization, the goal is to enhance full mobility of the nerve and reduce adhesions to allow the greatest pain-free movement. So the test position that will be used for treatment here has the client's wrist in a position of hyperextension here, and then we're going to move her into a position of shoulder abduction, lateral rotation, extension of the elbow, and at the very last step the client will also add in lateral flexion to the opposite side. And so when we perform all those together, here's what that will look like. And we'll go out and back in, and out and in, and out and in. Good. And you may want to repeat this about 6 or 7 times to get a nice degree of pull and stretch on those neural structures to really give them full mobility through that range of motion. But as we mentioned with the ulnar nerve mobilization techniques, ideally if any of these nerve symptoms occur prior to the full lengthened position, stop at that point and don't keep going past it. We want to encourage mobility in the nerve but not further aggravate any neurological compression symptoms.